is very common and of very much importance in today's aspect, like neuromuscular conditions and one neurodegenerative conditions I've tried to cover. How do we are treating now, and what are the future options, and what are the limitations we are facing? First disease which I am covering is Duchenne muscular dystrophy, which is the most common neuromuscular condition. Everybody must have seen cases of this condition. It is an X-linked recessive disease. Mutation in the DMD gene results in this disease, which protein codes for this gene codes for dystrophin protein, which is one of the largest protein. 1/3 of DMD cases are due to de novo mutations, and 2/3 of the cases are of familial origin, usually from a female carrier. So one should know that all cases are not transferred from the parents to child. Many are de novo mutations. So coming to the genetics aspect of this disease briefly. So large variety of mutations, 50 to 70% comprises of large deletions, 20% small deletions, insertions, point mutations, 12% are duplications, and remaining very few percentage remaining is subexonic insertions, deletions, splice mutations, and missense mutation. And very important to highlight this part, that no correlation between the size of deletion in DMD and the severity of the disease. So it doesn't matter how many exons are deleted. It doesn't match with any phenotype. There is no particular phenotype. Even one gene deletion will result in severe disease. So there is no correlation. What is the common presentation? How do we get patients and how do we diagnose in clinically? So symptoms are motor delays or abnormal gait, or most common symptoms. DMD are of normal height and weight at birth, but often fall below the expected growth curves during early childhood. This is because of increased metabolic demand due to underlying neuromuscular weakness. Other presentations, language delays, overall global developmental delays. So this is very important. So many times they come with intellectual disability or autism or ADHD complaints to our OPD, and then when we examine them, we find out there is calf hypertrophy, there is mild difficulty in getting up from the floor, and they have comorbid this condition also. So they come with autism complaint or intellectual disability complaint, and some very rarely they diagnose with comorbid Duchenne muscular dystrophy. And on examination, what are the commonest features which we find is this calf hypertrophy is universal. Other muscles are also getting hypertrophy. Tongue, deltoid, belly sign is there, Gower sign is there, wings of scapula. Very important, which I have highlighted here, is neck flexor weakness. Why I have highlighted this part is, so muscular dystrophies can be of different types. If you find a child with muscular dystrophy, you are thinking of muscular dystrophy, a male child, but if he doesn't have neck flexor weakness when you are examining, that is not DMD. Because earliest muscle to get involved in DMD is neck flexor. If that neck flexor is not involved, child is having neck flexors normal, but having all signs of DMD, like Gower sign is there, calf hypertrophy is there. So that is non-DMD muscular dystrophy. Scoliosis is there eventually because of muscular weakness, and then they also have lordosis and kyphosis. These are common clinical signs: scapular winging, which we will demonstrate by this particular maneuvers. Valley sign, which is formed due to hypertrophy and atrophy of some muscles. So you can see this valley-like formation here. And calf hypertrophy must have seen by everybody, but calf hypertrophy, you should understand that is not the DMD is not the only condition where you find calf hypertrophy. There are a lot of conditions, some even SMA type 3, Pompe's disease, even child who have diplegic CP, when they walk on toes, they will also develop calf hypertrophy, and there are other causes also. What I was talking about, neck flexor weakness. So they will have this invariably. They will not able to get up. they will not able to raise their neck when you examine in this posture. But extensors, they have strong, so when you examine them in prone position, they will lift their neck easily. So neck flexor weakness should be there. If you are thinking of DMD and there is no neck flexor weakness, most likely you are wrong. It is some other muscular condition. And this is classical modified Gower sign. Why we call it modified Gower sign? Because classical Gower sign is we get when we ask the child to get up from the supine position. This is we examine in OPD from sitting position, and we see that this is modified Gower sign, and we try to see this how much time the child is taking in the follow-up and monitoring of the condition. Again, this sign is not specific for DMD. It can be found in many neuromuscular conditions. So coming to treatment, other than supportive treatment, bone health, other immunizations. So mainstay of treatment as per today, like in all the guidelines, so corticosteroids has very important role and there is fixed doses, and it acts by help in reducing muscle inflammation, and many studies are there, it works, but definitely it is not a permanent treatment. It just delays the progression of the disease, and it also reduces overall mortality, because not only for ambulation, it also helps in preventing cardiomyopathy, preventing lung disease, which is bound to happen eventually. So that if you don't start steroids, eventually they will have cardiac involvement early, lung involvement early. So many patients ask me that now already the child has stopped walking, is there any role of steroids? So definitely there is role of steroids to prevent that cardiomyopathy part, to prevent that lung fibrosis part, but dosage has to be decreased. For ambulatory patients, we give 0.75 mg per kg per day. This is the most commonly used regimen daily, or some of the clinicians are also giving weekend off. Some of the clinicians are giving for 10 days per month, but most favored regimen is 0.75 mg per kg daily, and for non-ambulatory children, 0.3 mg per kg per day. Prednisolone is the most commonly used steroid. Many clinicians prefer deflazacort. Deflazacort has certain advantages, but it also has some disadvantages that in form of early cataract formation. Otherwise, it causes less weight gain, and many clinicians prefer deflazacort also. So what's new in this area, anti-inflammatory area, is vamorolone. This is also new, like very good non-steroidal anti-inflammatory, and it is being used in certain clinical trials and studies, and going to be effective, but again, it is not a definitive treatment. Doses I've already spoken about. So coming to novel treatment strategies, or you can say now already established, but not to the reach of everyone. Exon skipping, nonsense codon read-through, myostatin inhibitors, and gene therapy being investigated by CRISPR technology. So just understand what they do. So this is the normal DMD protein. First, you can see a wild type dystrophin gene, and it results in full-length functional mRNA. But if any exon is deleted, like here 50 is deleted, so the frame is stopped here. But if you skip a exon here, like just exon skipping therapy does this. So what happens is partial dystrophin protein will have short protein, but not the complete protein, but partial protein will form, and there will be theoretically improvement is possible. So based on this, development of many drugs molecules have been in process, and they are being tried, tested. They are effective also, but not like magic bullets. Like it is not like if you give them, they will be 100%, because this is partial protein expression only. There are different, for different exons, different drugs are there. Etlipirsen for exon 50, golodirsen for exon 53, and many new molecules are also being investigated. So one is stop codon therapy. This particular therapy, what does ataluren do? So stop codon read-through therapy resulting in full-length functional dystrophin expression. So here, what they do is this, the protein what is forming, it just read through, and it also taken into account that 51, 52 also. Like there is no partial, the complete protein formation is there. So this is one very established therapy for, this is particularly for exon 51 deletion, and not for other things. But again, availability is a big issue. And upcoming therapies, there lot of work is going on in myostatin inhibitors. Again, not a curative one, but and works on inflammation. Gene therapy can be curative completely, but again, this is not a treatment which is easily available. This is already people are using in some trials, and other trials are also going on: connective tissue growth factor, tamoxifen, coenzyme Q10, adibenone, granulocyte colony stimulating factors, and stem cell therapy. But as of now, there is no evidence of using them in DMD. So treatment is completely multidisciplinary. We also does this what we can do in our clinics. So diagnostics, then rehabilitation plan, orthopedic management, psychosocial management, cardiac, pulmonary management. Then they have a lot of smooth muscle dysfunction. Due to that, they have speech, swallowing difficulty, and complications also as and when they will have. Also remember, whenever we start steroid, before starting steroid, before 2 months, we should at least before 2 months we should vaccinate among, like, against the common infections, pneumococcal, varicella, and influenza. So that is the mandatory requirement before starting steroids. And also on every, like, at least we try to do every 6 months their spirometry, their pulmonary function test, which is bound to deteriorate with time, and we can improve them with medicines like cardiac. They have dysfunction, progressive dysfunction, and AC inhibitor has been proven to be very effective in their cardiac management. And general measures, as I've already told, calcium, bone health, this is very important. And 6-minute walk test for follow-up we use for many children who are ambulatory, and other follow-up in our clinics which we use is this Vignas arm for arm functions, Vignas arm test, and there are other measures also, like modified Gowers time also in a busy OPD. So coming to second prototype disease, which is a neurodegenerative one, Wilson disease. I will be talking about neuro Wilson. Commonest, like, what are the commonest presentation? There can be 4 presentation of Wilson disease: attenuated rigid syndrome similar to Parkinson disease, pseudosclerosis dominated by tremors, ataxia, and a dystonic syndrome full blown. Neurologically, deterioration of handwriting and school performance is the earliest clinical clue in Wilson disease. They will have developed mask-like faces, which is also commonly known as Wilson faces, and they will have hypersalivation, drooling, dull look, and this is a, like, before appearance of dystonia. If they can come to clinics at this time only, but it is difficult to diagnose at this time when they come. Psychobehavioral spectrum, they will present with sometimes personality disorders, affective disorders, psychosis, cognitive decline. We see all sort of this variety here. So they come sometimes just with psychosis, sometimes just with dystonia, sometimes very progressed disease, like this child who was presented in a bedridden state with continuous ongoing myoclonus. So you can see this ongoing jaw myoclonus, which is characteristic finding of SSP. But here it is in Wilson disease, this child is having ongoing jaw myoclonus. We initially thought it is SSP, but the child had suffering, which clinched the diagnosis in this child. And MRI was also very suggestive. have all the features. In fact, more than the classical features, even degeneration of brain has also started in this child because there is late presentation. He came after onset of symptoms. Like he has shown multiple places, but not diagnosed. So after 1 year, he has reached to our hospital, and this is the brain he had that at that time of presentation. So this is the classical panda sign, face of giant panda. So this looks like, so these are red nucleus which is paired, and you can see this classical giant panda appearance of this. This is one of the findings which you find in progressed Wilson disease. Other findings are caudate putamen involvement, striatum involvement. So this child was very bad, progressed, already cystic changes in brain, which usually doesn't happen in Wilson disease, but in a very progressed child, you can find all these findings. So what is the consensus statement? And this is what we follow also. Any child, young adult presenting with neuropsychiatric features, screening for Wilson disease should be considered. This is level of evidence is strength 1. KF rings are usually bilateral and present in almost all cases of neurological Wilson. Sunflower cataract is uncommon even in neurological Wilson disease. So don't just looking for sunflower cataract. It is only written in books. Very rarely we found this finding. Disappearance of KF rings often correlates with adequate chelation but may take years. So we also don't just keep looking for KF ring appearance or disappearance. We just monitor through serum free copper. This is the very good tool. I will tell you how to calculate it. Serum ceruloplasmin is usually less than 10. Borderline or normal levels do not exclude the diagnosis. MRI of brain will show striatum hyperintensity, giant panda sign, tactile plate hyperintensity is pathognomic of Wilson disease. And genetic part, ATP7B mutation analysis is recommended, especially now when we have this disease covered in rare disease program, and all the children can be benefited by treatment. So genetics proven Wilson should be there because differentials can be there. So it is better to prove genetically, and family screening is strongly recommended. Therapy wise, there are two slates, D-penicillamine and trientine. You can use based on your patient. There can be paradoxical worsening with the both, and monitoring for trientine when you are starting, you have to monitor for iron deficiency anemia, and for D-penicillamine, monitor for pyridoxine deficiency, and you have to supplement pyridoxine also with D-penicillamine. Zinc in all children. Most important is copper restricted diet. That has to be reinforced to parents that this is the main treatment. Chelation and all are secondary. If they keep giving copper, the disease will not stop. So drug therapy for management of dystonia, tremor, physiotherapy, occupational therapy has to be started when they already have progressed, and copper restricted diet. And serum free copper I was talking about, this is the only thing which you need on treatment. Whoever has already started on treatment, serum free copper is, you calculate it, you ask for serum copper, which is easily available in labs, serum copper minus 3 into ceruloplasmin. So this is a formula which will give you serum free copper. And if serum free copper is 5 to 15, then you are having adequate chelation or you are achieving your goal. If it is less than 5, you are over chelating. And if it is, so moving to the last prototype disease, which I am discussing in brief, spinal muscular atrophy. So SMA, again, a very bad disease. Dr. Priyanshu is here, has provided treatments to many, some of the lucky children who got the treatment. SMA, definitive treatment, routine, that supportive treatment, everybody we are trying to give. We are also trying to procure these drugs to rare disease program, NPRD, but it is actually very difficult, but we are continuously trying. Kuldeep sir is doing a lot of efforts in this field. SMA is characterized by degeneration of alpha motor neurons of the anterior horns of the spinal cord, resulting in progressive muscle weakness. We all know that a lot of type of SMAs are there, but what we are talking about here is classical SMA, axon 7 and 8. And so SMN1 is deleted, and SMN2 based on SMN2 copy you get your phenotype. So larger the copies of SMN2, less severe is the phenotype. So SMN1 very like hardly any SMN2 copies or 1 or 2 copies will be there, and they will have infantile presentation. And SMN2, SMA2, SMA3, they will have more copies of SMN2. So SMA type 1 non-sitters less than 6 months they present, type 2 sitters 6 and 18 months, and type 3 more than 18 months. Many of patients I have seen presenting first time around 10 years. So they are SMA3 maybe or SMA4. I have seen patients coming to me with parents affected, but they were not knowing. So they're probably SMA type 4. This classification has become obsolete now because of newer therapies which are now changing the course of the disease. These are the classical signs just for students in the audience to show. The fasciculations should be, so even if you are not able to appreciate, just remember you have to examine in the tongue should not be protruded, child should not be crying at the time of examination. Otherwise, you will have pseudo fasciculation appearance. In older children, sometimes fasciculations are absent, and this hand tremors, polyminiomyelitis, is the clue. It is also a type of fasciculation which you find in your distal muscles. So this is, and whenever we find this findings, history suggestive. So one bedside test we do is ECG, and we will find ECG cardiac leads. We will find fasciculations, and we will confirm most likely it is SMA, and we'll send the genetics and confirm the disease. So coming to some new drugs of this, not new now, but but still many centers are struggling to get them. Already 4 or 5 years people are using them in India itself, but cost is an issue. Nusinersen, I think Dr. Priyanshu has used, I think, all 3 of them. Okay. Okay. And I think you have found good results. So they are working, and I have spoken to my colleagues like USA. They were also very satisfied with SMA drugs. DMD they are not so satisfied, but SMA definitely these drugs are working. They work by different principles, but what they do is increase SMN protein, and even like some of them just like risdiplam just increase SMN2 copies, SMN2 protein. So it will not interfere with SMN1, but it will increase SMN2. So it will increase the functionality. So I will not be discussing in this mechanism and all this. There are a lot of trials and drugs. So just names: nusinersen, risdiplam, and jognasma. Jognasma is a gene therapy. Again, what we should not forget is, like in DMD, all multidisciplinary care, it has to be going on. And now there is a recent concept, because now they started surviving. These children, they have like cognitive issues. So that has to be also psychological support. Also, we should be from beginning also only should be started. Thank you. हम देते हैं 50 mg period, that is the maximum dose, and that is the minimum dose also, because usually these children are diagnosed around 5 years of age. Beyond 5 years, you can use this dose. And also, I have not mentioned, that is not in the guidelines, but like this is my personal experience, you can say, but I published also 2 papers on this. Thiamine is also one agent which you can start in these children. It also works very well. It also does the work of, competitive for absorption. It does not allow copper to get absorbed from the gut. Thiamine also you can give. It is very safe, water soluble thiamine. So I am giving it to all my children. I published this also. SMA, definitely these drugs are working.
So, okay, this is a very nice presentation from Dr. Lokesh. And I think the carry-on message is that for both pediatrician and obstetrician, that is, if our minds knows, then we can diagnose them. And also, the therapy becomes easier once the diagnosis is established. And once the diagnosis is established, we can go with the prenatal diagnosis. Although patients with the DMD, it is very difficult because they have already completed their families. So awareness about these simple signs and that we have to have the high index of suspicion for this disorder. So if they can be diagnosed, they can be treatable. For example, Wilson's. Similarly, for SMN, we have now easily available methods for diagnosis. So they can be diagnosed with ddPCR, which takes hardly 1 or 2 days to give the result. So sequencing may take a little time, but I think this will be very helpful. So awareness about these type of treatment, diagnostics, and also the prenatal will be helpful for neurological conditions.